Morning, everyone. Thank you, Shweta, and thank you for joining. I'm going to talk about infection control related to tuberculosis. This is a subject that often generates a lot of questions. We understand that several of you may be newer to tuberculosis, and we'll try and go over some of the basics. But we'll also be discussing some major updates to guidelines for tuberculosis isolation, which came out earlier this year. So, um, um, we will be talking about when is the right time to put a person into isolation, to when you're worried about tuberculosis, when is it safe to remove a patient from isolation, what's the best way to protect you and your staff from TB infection, and how to reduce the duration of isolation. Because keeping patients in isolation is a headache. It is hard on patients emotionally, it's hard on the medical staff, it slows down care of patients. And so we are quite aware that isolation, although it is very necessary and very important, the less time in isolation, the better. Now we know about this general slide where a person on the left has red dots with tuberculosis in the lungs, and when this person coughs, the droplets are spread through the air, and someone else will breathe in the droplets, and we want to try and prevent that transmission from one person to another, and that's what we're working on. Now, before we talk about tuberculosis, I just want to talk about your car that you drove to work this morning, because safety in your car is sort of similar to safety in preventing TB. You know, your number one way that you're going to prevent a car accident on the freeway this morning was to be alert and watching the road ahead. That is by far your biggest safety protection. You do have brakes to slow down in case you see something ahead. And if you do have a collision, then there are airbags to protect you, but you really want to prevent having to slam on the brakes or use your airbags. Similarly, for infection control for TB, your number one protection is what we call administrative controls. That sounds boring. It's not really your administrator telling you what to do. It's all the policies and training and education that you have in place. These are programs to educate your staff on what TB can look like, how TB can present in your hospital or your emergency room, how it can look on an X-ray, and how to be thinking that the patient might have TB before you run into trouble. Now, if you think the patient might have TB, then you're going to institute environmental controls such as a private room, special ventilation, and then you're going to wear a mask for respiratory protection as your final level of protection. But clearly the most important is the top part, and that involves our brains. That means our brains have to be functioning and thinking about the possibility that it might be TB. This is difficult in this day and age because TB is down dramatically in the United States in most areas. So there's less TB, there's less experience with it, and oftentimes it's forgotten as a possible cause of a patient's illness. So I put a big arrow here on the right that administrative controls involve the brain of this person on the right to prevent TB from getting into his lungs. We want to do things in the environment to prevent aerosols from getting into that person, but the brain of the person is the most important function in protecting us. Now, if you're a doctor, or if you're in triage and emergency, or if you're in a pulmonary clinic or an infectious disease clinic, we want you to start thinking about TB if someone has a chronic cough. In other words, usually a cough that lasts more than 2 or 3 weeks. We don't want to investigate cough that started on Monday, We don't really want to investigate upper respiratory infections or COVID suspects very much. We're thinking more of a chronic cough that maybe started at the beginning of August and persists. We want to suspect TB if someone comes in with gross hemoptysis. Now, gross means like a spoonful of blood, not little dots of blood, but gross hemoptysis should be a warning sign to make the doctor think about tuberculosis. It could be something else like an embolism in the lung or a cancer or something like that, and those would be the most common. But if you don't think that TB could be a cause of gross hemoptysis, you're going to miss it until a number of people have been exposed. You're going to suspect TB if the patient is sick and says they've been exposed to TB in the past. Maybe they were born overseas, or maybe they had exposure to TB when they were younger. You're going to suspect TB if they've had if they're known to have a positive skin test or IGRA blood test, such as a quantiferon. You're going to be more suspicious of TB if they come from an endemic country. As you may know, some countries have 100 times the incidence of tuberculosis than United States. So someone coming in from Asia with respiratory complaints and abnormalities on their lungs might be 100 times more likely to have tuberculosis than someone who was born and raised in Michigan. Also, you'd be more suspicious for TB if someone is a marginalized patient, a substance abuser, or HIV positive. So here's an example in my hospital a few years ago. A patient came into the emergency room, said she had blood in her vomit. Well, it was really blood in her sputum, but it got mixed up. The patient says she was pregnant at 30 weeks. She was not having any spotting. And she said that she had been diagnosed with pneumonia 1 month earlier and had been hospitalized at a different hospital. Here's someone who has gross hemoptysis, someone who's been coughing for more than a month and had, quotes, pneumonia. This should start to raise some eyebrows and make you a little anxious when you're sitting in the triage in your busy, chaotic emergency room. The emergency room doctor, she was wide awake that day. She was really, really good. She heard the report that the patient had gross hemoptysis. She asked the patient said she coughed up 2 tablespoonfuls of blood. The doctor noted the patient was originally from Africa, so she would be from a higher incidence country for tuberculosis. And so the emergency room doctor says, put a mask on this patient, put her in an airborne isolation room, and protect the staff even before getting a chest x-ray. Now, I congratulated this doctor for being so alert and so conscious of this risk, because this patient was basically put into isolation within 10 minutes of arriving in our emergency room. And this patient was found on the right-hand side. I don't know, Shweta, if you can see my mouse moving around, but there's a cavity here on the right lung. It was easier to see on the CAT scan than it was on the x-ray, but this patient was found to have cavitary tuberculosis while she was pregnant, but we got this taken care of, and my emergency room doctor should be given a trophy for being so alert to this possibility. Now, 99% of the time, gross hemoptysis is going to be due to something else, but you always have to keep TB as one of the possibilities. So the most important component for infection control for this situation in the emergency room was the administrative component, the boring thing, the training of your staff, the policies, the education of staff, and cognitive awareness on the part of the physician. Now, we're probably going to do this 10 times to discover a single case of tuberculosis. In fact, we might have to do isolation 20 times to discover one case of tuberculosis. But to miss a case is a giant problem and can expose a large number of patients. Every year in our hospitals, we will have 1 or 2 situations a year where patients are not isolated for pulmonary tuberculosis because it was never considered as a possibility and caused major exposures to hospital staff. Now, I also want to emphasize that 99% of TB transmission occurs before it was diagnosed. So, in other words, all the transmission of TB is probably happening at the home of the patient when they were sick for weeks with coughing prior to any diagnosis. So the box on the left, the pre-diagnosis period, which can be weeks or months in some cases, there's a much higher risk of transmission then. In the middle box, once the doctor considers TB, the patient is put into isolation and transmission is going to be greatly reduced from that point on. And then when the patient is put on TB treatment, there is rapid reduction in transmission within the first 5 days of treatment. We spend a lot of time when we're in the right-hand side of the box when a patient has been started on TB treatment. We spend a lot of time worrying about the patient transmitting to other people when they're on treatment, whereas really all the problem was in the weeks or months prior to the consideration of tuberculosis. Now, on the right-hand side, when patients are on treatment, we still have to take precautions, but we will discuss how the recently updated guidelines have shortened the length of time that patients on treatment require isolation. Now, there are 7 factors that can affect how infectious or how contagious a TB patient is. If a patient is coughing, obviously they're going to be making aerosols, and that's going to be worse than a person, for example, who is not coughing. If a chest X-ray shows a cavity in the lung, that means there's like an abscess in the lung, and there might be 1 billion TB organisms inside a cavity. Those are going to be more contagious than someone who did not have lung cavities. If the acid-fast smear is positive at the time of diagnosis, that means that the patient has more bacteria than someone who has a negative acid-fast smear, and those patients are considered more contagious. Certainly when TB is in the lungs or could be upper airway or larynx is considered highly contagious. If the patient is not covering their mouth when they're coughing, if they're on inadequate TB treatment, which we hope won't happen, those could be a problem. Patients could be quite contagious during cough-inducing procedures. So if you're doing a bronchoscopy on a person because they have a lung mass or a lung nodule, and you're making them cough a lot because of the bronchoscopy, and this turns out to be tuberculosis, that's going to make that case quite infectious. Now, putting someone in isolation or airborne infection isolation, some hospitals call this AII, involves putting the patient in a private room. You want to have special ventilation with negative pressure so that the air in the patient's room does not drift down the hallway into other patients' rooms. It's going to be removed out the ceiling and filtered. Our negative pressure rooms at our hospital have 6 air exchanges an hour. That means every 10 minutes, all the air is replaced with fresh filtered air. If it's a new hospital construction, the guidelines are now 12 air exchanges per hour. So the air is quickly being circulated and sucked out and kept away from going towards other patients. You're going to have to put a sign on the door, and I'll show you an example of a sign at our hospital. And the staff are going to wear N95 respirators. We're all used to N95 masks now. Now, this is a sign that we use at our hospital, and it's in Arabic. because we have a large Arabic population in our community in Southeast Michigan. And you may need to have culturally sensitive signs. English signs may not work for everyone. And you don't want family or neighbors walking in not aware that the patient is in isolation. So you may want them in English and the language that the patient's family speaks. Your hospital engineers spend a lot of time working on the mechanics of the ventilation and making sure that the negative pressure room is functioning well. This can require some complicated engineering to do. The ventilation can get messed up. There are gauges at the entrance to the room that show you that the room is negative pressure. And if it's not, a little alarm can go off. And sometimes you have to call your building engineers to fix it. We had problems at our hospital 5 years ago when the air conditioning came on. All the ventilation was needed to be recalibrated. And so these require expert management and usually have to be inspected twice a year to prove that there are 6 to 12 air exchanges every hour. So you'll end up working with your hospital plant engineering department. We're going to wear N95 masks, and we're all used to N95 masks because of the pandemic. But N95 masks really came into use about 30 years ago when tuberculosis resurfaced in the United States as a problem. These are tight, these are stuffy, they get a little bit hot to wear, but it's intended that all the air that you breathe in as a healthcare worker is going to get filtered so that you don't breathe in droplets which could contain tuberculosis. These have to fit properly. There are different sizes. Sometimes you have to be fit tested at the hospital. Now, on the other hand, those paper surgical masks are given to patients. Patients with TB may cough, and you want this mask to trap droplets so they don't go out. But we don't give patients N95 masks. They're too hot and too restrictive for patients to wear. But this is what a TB patient would wear if they're going down to CAT scan or for some procedure. Now, one thing that I always experience at our hospital with healthcare workers is the placebo mask. A placebo mask is a mask that's not put on properly. You know, when there's a patient in isolation and someone has to go get the food tray or someone has to go in and just turn off an alarm on the patient's IV pump. And so you just use one strap and you just run in the room and quickly do your thing and run out. That's a placebo mask. Or you can just hold it to your face for your quickie little visit. Or if you've got a lot of facial hair or a beard that interferes with it. We always have to counsel our staff when we see them taking shortcuts with putting on their N95 mask to protect themselves. It's a bit of a pain sometimes, but it's there for their own protection. Now, let's go back to that pregnant woman. My emergency room doctor was smart. She recognized this pregnant woman had gross hemoptysis and she was diagnosed with tuberculosis. And so she's admitted to the hospital in an isolation room. When can that emergency room downstairs be used again for another patient? In other words, how long does it take any TB aerosol droplets that could have been in that room in the emergency? When is it safe for a regular patient to go back again? It's not an uncommon question. Does it? And it takes about 45 minutes to remove 99% of the contaminants. This is when you're in a negative pressure room. The air is recirculated. And so we consider 60 minutes or an hour to be sufficient time to remove more than 99% of any aerosols from that room, and then it's safe for someone else to use the room. Now, on the other hand, since it's a big nuisance putting patients into isolation, let's say you have someone, they come in the emergency room with gross hemoptysis, you don't know if they have TB. 90% of the time, or maybe more than 90% of the time, they don't have TB, they've got something else. They've got a pneumonia, they've got a blood clot in their lungs, they might have a malignancy or something, and keeping the patient in isolation is a pain. So how do we get them out quickly? Well, you want to get good quality sputum. That means that rather than just put a little cup at the bedside, you may have to go in and coach the patient. You want a good, deep sputum. And you can say, if you give me a good sputum, maybe we can get you out of isolation quicker. Patients who are sick may not understand on how to do that. You may have to use a nebulizer to help the patient cough. That means respiratory therapy has to be educated that this patient might have TB, but please nebulize this patient so we can get a sputum that's good and deep quality. You're going to want to order an acid-fast smear on that specimen, and now most laboratories are automatically doing a nucleic acid amplification test, or a NAT, or some people call it PCR. And that test is now being done more and more, regardless of whether the sputum AFB smear is positive or negative. So we have a good setup at our hospital where we obtain a sputum, we send it to the laboratory, and they'll do a smear. But remember, a smear is just a crude way of looking for tuberculosis. Our laboratory will automatically do a NAT on that first sputum so that we less likely to miss a diagnosis of tuberculosis. And that's very, very helpful. And that is becoming a standard of care around the United States. In some hospitals, you still have to personally call the microbiology lab and request the NAT be done.
Dr. Sundstrom, there's a question in the chat.
Sure.
By Ann Rickard. It says, when can you use a room again after a TB patient has been in there if it's not a negative air pressure room?
Oh, if it's not a negative pressure room, then it would probably be a couple hours. Even regular rooms do have ventilation, and so they're not closed spaces. There is air movement. So I would say 2 hours if it was a non-negative pressure room.
Thank you.
Any other questions out there?
I don't see anything else in the chat.
Okay, so let's say you've got a patient in isolation, you're worried they might have TB, but then how are you going to quickly get this taken care of? Because if you're suspecting TB and the patient has some other problem, like a malignancy or a blood clot, you don't want to delay their treatment for their real problem, but you still have to rule out TB. So there are guidelines that the National Tuberculosis Controllers Association has generated on how to use the NAT test, and this is the one company that's very popular is called the expert test, although there are others. But this is on how to use the NAT test in making decisions on discontinuing isolation when patients are in the hospital. And this looks a little bit complicated algorithm, but basically, if you're going to get sputum and you want 2 negative NATs to say the patient clearly does not have tuberculosis. Because the reason why you want to do 2 in the hospital is you don't want to release this patient from isolation too soon and potentially expose other people. So you can look at this document in more detail, but that's the safest way. That way, you've got a patient, let's say, who comes in with gross hemoptysis. You've done 2 sputum specimens, and if the nucleic acid tests are negative on both, then you can say with great confidence this patient does not have contagious TB, and you can take them out of isolation and get to work on their real problem. And this approach has greatly reduced the time that patients would be stuck in isolation. There's nothing worse than having someone stuck in an isolation room for 7 or 8 days while you're fiddling around with these tests. So looking for DNA with the nucleic acid test is a great help. It's also very helpful if you have the test available in your hospital. So bigger hospitals often have it available right in their microbiology lab, and we can often get a result on the nucleic acid test within 4 hours of obtaining the specimen. So if we asked for it now at 10:30 in the morning, I could give you an answer by 2:30 this afternoon, and I could say, no, this patient does not have TB, and the tests were negative twice, and take the patient out of isolation, get to work on their real problem. So we can discontinue isolation when infectious TB is considered unlikely, and either another diagnosis has been made because you may have already done tests to find another thing, whether it's pneumonia or a blood clot. If the patient can have either 3 negative smears, but really what we prefer now is the last one. The patient has a sputum that has a negative nucleic acid test, and probably twice, assuming you get good sputum. We do not like to send saliva to the lab. That patients oftentimes will just put a little bit of spit into the cup. They need to be coached to get a good deep sputum sample. Now, so that's the patients who you put into isolation because you're concerned and you're anxious and you don't want to miss a case of TB. Now, let's say you've got a patient, you put them into isolation. Oh, and the sputum test is positive by nucleic acid testing, and it says the patient has tuberculosis DNA in their sputum. Then your infectious disease doctor is going to come and put the patient on your 4 TB drugs, your isoniazid, rifampin, your pyrazinamide, your ethambutol, and the patient starts to take these pills. And then the big question is, how long does this person need to stay in isolation once you've started treatment? This question has generated the most arguments and disagreements of any question in the tuberculosis field, because it's difficult to do a test that says suddenly that this patient is no longer contagious. And so, but what has happened over the years is that a number of patients were kept in isolation, either in the hospital or restricted at home and prevented from going to work far too long because of misunderstandings about this. And so last year, the National TB Association brought a group of experts together to say, let's look at all the scientific data. Let's look at this subject. We had not really looked at this question for over 20 years, and they've issued new guidelines to help us. Because it's now shown that patients rapidly become non-infectious once you've started multiple drug therapy. The 4 TB drugs that we give to patients quickly cripple the bacteria. They damage the bacteria and make it much more difficult for TB to be contagious. Now, it may not be. You may still see them on the smear. They may still be present in the cultures, but they are crippled organisms. Once the drugs rapidly eliminate viable or contagious TB from the sputum, and there's usually reduction in cough frequency that happens within the first week of therapy. And decreased cough also equals decreased transmission. But there is no exact special test to say where you can just grab a sputum on a patient and examine it and say, oh, this person is no longer contagious. We don't really have a test like that. So this major update that was issued in April, and here's the web link for the article. Now it's quite long and it's quite scholarly and presenting all the data. But this has been very helpful in explaining to public health staff how long patients should be in isolation. Now, I will be the first to admit that even in our county TB clinic, these guidelines are still being read and reviewed and discussed quite a bit. In other words, these guidelines are shortening the length of isolation for many of our patients, and many of our team is still getting used to this idea of less isolation rather than more isolation. And this requires a lot of discussion and review of these. It's not a quick, simple, easy thing to implement sometimes. The summary of the guidelines says that the overall risk of transmission to others should consider PWTB as abbreviation for person with TB. So you have to consider the patient's infectiousness as well as other factors, including the environment. In other words, where does this person live? Where does this person work? How long were people exposed, the duration of exposure, and the biological susceptibility of contacts. Now that's kind of a mouthful and it sounds kind of complex, but basically what this means is, where does this person live? Are they in a stable house with stable food and stable family life, or are they living in a homeless shelter or living on the streets? That would not be a good place. You want to evaluate the biological susceptibility of the context. That means, do they live with someone who's vulnerable? Perhaps your patient with TB lives with children who would be highly vulnerable, or maybe they live with someone who has a transplant or has HIV, and so you want to be careful if there are susceptible people at home before you lift isolation. Now remember that once you put a person with TB on TB medications, 99% of their transmission is going to have occurred before the diagnosis was even made. Now, a person with TB on less than 5 days of therapy, ATT is abbreviation for anti-tuberculosis therapy. If they're on for less than 5 days, they are considered relatively more infectious than those people who've had more than 5 days. So the main take-home message of this document is that if a person has taken 5 days of TB therapy, they are very unlikely to be contagious. And then you can start to think about taking them out of isolation at home. Now, this does not mean taking them out of isolation in the hospital, because patients in the hospital, of course, are close to other vulnerable people, and they could be on the pulmonary service or the cardiac service or the oncology service. And so these guidelines and these 5-day guidelines are mainly applying to people who are at home. Patients on therapy for at least 5 days should be considered non-infectious or having a low likelihood of being infectious, in other words, greatly lower, regardless of what their sputum looks like. In other words, in the past, we used to say, oh, you have to have negative smears, negative acid-fast smears, before we take you out of isolation. That turns out to be wrong, in that using acid-fast smears can keep people in isolation for weeks or sometimes months, because patients will be coughing up dead acid-fast bacteria, and dead bacteria are still visible on the smear. So that really doesn't tell us the contagiousness. And that is probably one of the bigger recommendations, is not to pay attention to the AFB smear in terms of determining contagiousness. There are a couple exceptions to that, but that's the general statement, and I agree with this. They use a lot of abbreviations, and I apologize. RIR means respiratory isolation with restrictions. This is not recommended for people with non-infectious forms of TB. In other words, localized lymph node tuberculosis or some other part of the body where there's no pulmonary involvement, where you've done sputums and lung imaging, which is normal. So a person with lymph node TB, for example, who has a normal chest x-ray and no symptoms of respiratory problems, would be put on TB therapy and would not need isolation, period. That's an important statement to make. People with pulmonary TB on effective therapy and a low likelihood of infectiousness, so that they've been on for more than 5 days, should not have restrictions in most circumstances. In other words, isolation should be removed. Now, there are exceptions for a person who would live in a high-risk community setting, like a homeless shelter or a nursing home, or if there were children or immune suppressed individuals in the house, then you may keep those people under isolation a little bit longer. Maybe instead of 5 days, you might have them in isolation for 15 or 20 days, just to be sure. So there are some special circumstances, but for most of our patients, these situations would not apply. Now, I just want to show this as an example. This was a patient that we had who was started on TB treatment. And in the table, you can see before the treatment, the patient had very strong positive smears. The patient had a positive nucleic acid test, and the patient had a positive sputum culture. By 14 days, the patient still had positive acid-fast smears. We do not repeat the nucleic acid test because that's only used at the beginning to make the diagnosis. The acid-fast culture is still positive at 14 days. However, within 5 days of treatment, this patient was probably not contagious. And so we used to say in the past, oh, you still have positive smears, you still have to be in isolation, you can't go to work, you can't go outside or anything like that. And now we realize that you can have positive AFB smears for weeks after initiation of treatment. Here you can see in this patient, it was not till 60 days that we had negative smears, but we quickly had negative cultures. So in this case, this patient really was probably not contagious after 5 days of treatment.
So, Dr. Sundstrom, there's a question
Yes.
again in the chat. How about for patients who might have drug-resistant TB?
Drug-resistant TB is a whole nother can of worms. And so if you're worried about drug-resistant TB, then much of this would not apply. Now, remember that 98% of our cases are drug susceptible, and only 1% of cases in the United States are MDR tuberculosis. So if for example, your patient was a contact to someone who had drug-resistant TB, you would be using stricter rules. If this person, for example, had treatment for pulmonary TB 15 years ago and has TB again, a recurrence of TB would be higher chance of drug resistance. Now, your NAT test, for example, at our hospital, we use that expert, or the gene expert NAT, that can quickly tell you if there's drug resistance to one of the drugs, to rifampin. So if you find any suspicion of drug resistance or concern, or the NAT is positive for resistance, then you're going to be more cautious. But I think, a similar principle is still in effect in that even if you have drug-resistant TB, once you have that person on the right drugs and you know the person is getting the correct drugs, they quickly become non-contagious. But in that case, you're still going to have stricter guidelines to prevent transmission. Hopefully that doesn't happen very often. So the scientists, when they did this review of the literature, and they went back and they found scientific data showing that when you start someone on 4 TB drugs, that you have a 90% reduction of, of viable tuberculosis in the sputum in 48 hours. In other words, after 2 doses of medicine, there's a 90% reduction in the sputum. Now, there's still lots of TB in the lung itself and in the cavity itself or in the pleural fluid itself. But what's coming out in the sputum is heavily damaged and dying quickly, and a 99% reduction by 14 days. So what they've been able to say is that 5 days is going to get your burden of TB in the sputum down by probably by 95, 98%, and the patient is coughing. And even those organisms that the patient is bringing up are damaged and they're sort of dented. And so they might be alive a little bit, but they're not really able to be spread to other people. This is a great victory for us in terms of how effective TB therapy can quickly reduce transmission. Now, you've got the patient in the hospital, you've got them on TB drugs. Is the patient going home or remaining in the hospital? If they're going home, they could go home the very next day. They've already exposed everyone at the household long before they were diagnosed. If they're staying in the hospital, then you have to be a little bit stricter. But if they're going home, they could go home the next day. They don't have to be in the hospital for 5 days or 7 days or 21 days. They've already exposed the people in the household and they can go home. So for example, if you diagnose TB in a patient yesterday and the patient has a stable home arrangement, they could go home today on directly observed therapy. You've got no obvious risk of drug resistance. You're going to arrange directly observed therapy. The patient would be in home isolation for at least 5 days of treatment, but you don't have to lock someone up in the hospital for a tuberculosis diagnosis. In fact, we prefer patients with active TB to be at home rather than being in close proximity to other vulnerable patients and occupying a negative pressure room, which requires more intensive medical care. But you have to have a patient who's capable of taking care of themselves, who understands what's going on, who's going to be cooperative, and there's no obvious immune suppressed person or children at home, and they agree to directly observe therapy. And this is often the case. So patients don't have to stay in the hospital a long time. So I'm just going to stop there and take questions. This is a subject that generates all sorts of questions. And so let's see what kind of questions came up from this.
Thank you, Dr. Sandstrom. There's also another long question from Kyle Wolding. I'm wondering if you're able to unmute and explain a little further about some of your comments in there.
Yeah, for sure. Thanks so much for this talk. It was super interesting. I'm one of the ID doctors at the New York City Department of Health, and we've been discussing this 5-day duration as well. I'm trying to incorporate it into our workflow since it's got like sort of protean effects. But my colleague and I were just talking about semantics the other day, the term infectiousness versus contagiousness when we're discussing TB. I know it's sort of like ancillarily related to this talk, but I'm just curious if you had any thoughts, because it seems like we use that term, including like CDC publications, to talk about the transmissibility of TB, but it is a bit different in my experience than the way that we use the term infectiousness versus contagiousness with other infectious diseases. No worries if you didn't have specific thoughts, but I was just curious.
So it's a good question. And I mean, I consider the two interchangeable, although contagiousness is more in the lay understanding of disease and so on. But I think I would consider them equivalent. Would you?
I think historically, yeah, I think from a communication standpoint, I think people definitely understand infectiousness versus contagiousness as, with the way that we talk about TB, but sort of classically, the way that I thought about it historically was infectiousness is how an infectious agent causes an infection and disease in a patient, whereas contagiousness is actually the transmissibility of that agent from host to host.
Uh-huh.
Um, but again, like these are the terms that we use when we discuss TB, so maybe it's a moot point, but just sort of curious about that.
Yeah. I'll have to meditate on that a little longer.
But thanks for the talk. Yeah, it's super
Uh,
interesting.
and have you in New York City? Have you had the confidence in taking a person out of isolation after 5 days of therapy and letting them go back outside to the park, or maybe going back to a construction job where they're working outside and not indoors? Have you done that yet?
No, it's a great question. I'm new to I just graduated ID fellowship like 2 months ago and just started at the Bureau of Tuberculosis Control. So I'm new here, but we did just have a meeting very recently to sort of start planning the incorporation of this.
Yeah.
So it is not, it's not standard practice for us yet, but I think we're trying to figure out how we move to this because obviously saves a lot of inpatient resources, gets patients back to their lives and their families faster. Um, but I think, we were talking about the challenge of getting all of the necessary steps in place with a shorter duration of time
Yes.
to do it, like the case management considerations.
Right. And don't get me wrong, these guidelines just came out in April. It's going to take TB programs a good year or more to digest this information and think about it and understand it. And I think really, we often like to present challenging TB cases at conferences, right? But
Right.
the challenge usually stops once you've made the diagnosis, and then patient goes on treatment and lives happily ever after. But I think we should present, 10 examples where you've made the diagnosis, and then when do you lift isolation?
Exactly.
And how, because if you put a bunch of doctors in the room, you're going to still get a variety of answers.
For
and
sure.
and that's okay. But what we're trying to do is prevent people. I can show you numerous examples where patients were kept away from their job and kept away from some of their family for 10 weeks because the sputum smears remained positive, even though they were improving, even though they had
Definitely.
drug susceptible TB, even though they quit coughing, and they were 100% reliable with their treatment. But because the smears remained positive, they were firmly instructed not to go out with anything. And that was a really unfortunate prolongation of isolation for patients. But that's what the previous guidelines said.
Right. Right. No, it's interesting stuff. Thanks so much. Appreciate it.
Sure. Thanks for joining.
Yeah, thank you for the great discussion. We have another question again. It's in the chat, which is if there are young children in the home or immunocompromised people, would you isolate the TB patient in another place? And if so, for how long?
Yeah, well, that's a tricky question. The most important thing is to get those children or immune compromised people evaluated. In other words, those children or the immune compromised person needs to be seen at the TB clinic. You need to do a skin test or a quantiferon blood test. They're probably going to need to have an X-ray to see if they're showing any sign of TB disease. And so that is really the biggest thing, is they need to be seen. And remember, the CDC gave us guidelines a long time ago that once you determine that a patient has active pulmonary TB, the health department is supposed to evaluate and examine the close contacts within 10 days, which is a big headache. It's a real scramble to evaluate and get those children in for skin testing and x-rays and a quick check by the doctor, or get the transplant patient in for evaluation within 10 days, because those patients can decline faster, and they may also deteriorate without it looking like regular TB. So first of all, that evaluation of those vulnerable people needs to be done first. Then you need to start your patient on proper therapy, and then you would probably keep isolation in place, maybe more to the previous guidelines of 14 to 21 days of treatment, and then lifting isolation. That needs to be done on a case-by-case basis. But again, there really should not be any good reason for keeping the TB patient in for weeks and weeks and weeks of isolation in that setting. And remember, 99% of the risk of transmission to those vulnerable individuals occurred before the diagnosis was ever even made. Any other questions?
No, I don't see anything right now. Does anybody else have any other thoughts or comments? Well, okay. Well, thank you so much.
Thanks everyone for joining.
We hope you all have a great weekend.
Bye.
Thanks, everybody.